This is Javad Parvizi. I'm a professor of orthopedic surgery at Acıbadem University in Istanbul. I have an amazing podcast for you today. I'm talking to one of my greatest friend and greatest, the scholar surgeon, Dr. Mark Spengel from Mayo Clinic, Arizona. I've introduced him to you in the previous podcast. He's one of the most incredible people I know, skillful surgeon, dedicated educator, and of course, he has impacted the field by his brilliant research that spans over the last 2 or 3 decades. And I've known him for a long, long time, and I have learned a great deal from Mark. And he will most likely be replacing my hips very soon in the near future. Mark, it's a pleasure to have you on this podcast. You worked very tirelessly for the ICM. You covered many questions. You were part of the leadership. But one of the questions you covered, which is very pertinent topic, is the topic of double dare. And I know you have published on this subject. Can you tell us why you covered this during the ICM and what did you recommend?
Yeah, sure. First, thanks for that kind introduction. I think it may be a little bit embellished, but I certainly appreciate all your kind words. It was a real pleasure to be part of the ICM and to be able to, meet with others and deliver some of, deliver and learn from others. It was a great meeting, and so. Yeah, Double Dare is one of the topics that's very dear to my heart. We probably started doing that now well over 2 decades ago. If you go back 2 decades, the literature was pretty clear that the results of a single dare, and I think there's maybe a lot of reasons behind it. I think all of our techniques have improved, but regardless, the results of a single dare were really not at all favorable. And so we thought, well, how can we improve these results? And if we can deliver high dose antibiotics with antibiotic beads and give a second washout, maybe we'll have improved results. And that's really the essence behind our protocol and our technique for double dare. Basically, they get, the initial washout, thorough debridement, remove the modular implants, try to soak them in an antiseptic, meticulously debride the joint, put those modular implants back in again, put in high dose antibiotic beads into the joint, and then come back 3, 5 days later, remove those beads, another thorough debridement, and then put in the new modular parts. And with that protocol, we were able to improve our success rate dramatically from at least historical controls. And then if you look at some of the other literature, there is other literature that it actually looks at the effectiveness of a second debridement, just simply what happens when you go back and give a second debridement. And it's generally pretty favorable. I think you have to also be careful how you interpret that. If you only look at patients who have failed the first dare and only include those as a second dare, you're going to get a lower success rate. But if you say, for example, take 100 patients and, 60% of them do okay, 40% don't, and then that 40% gets a second dare based on ongoing infection, and you can cure another 50% of those, then you've actually improved your numbers for the entire cohort. So some of the literature I think is a little bit flawed in its interpretation of the ultimate outcome of a second debridement. They often only conclude on the patients who have failed the initial dare, but if you look again at the entire patient population, it's actually pretty convincing that a second dare is beneficial and can improve your overall success rate.
That's a
So
that's very
that
important point that you make there. So you're talking about double dare, planned second dare procedure a few days down the line, not waiting for them to fail and require a second dare. Very important.
Yeah,
This,
sorry, I might have sort of mixed up the sort of topics there in the sense that, I initially talked to you about our own protocol, which is a planned double dare. That's correct. And we have been doing that here at our shop now for a couple of decades. Um, The other point that I wanted to make is when you look at the literature on just a second debridement, that's not necessarily always a planned second debridement or a planned, double dare, but it is taking patients who, may not be responding quickly and having them undergo a second dare. And there is some data that shows that the earlier you do it, if you wait past 2 or 3 weeks for the second dare, the results of that aren't as good. But if you do that within the first 2 weeks, or ideally even a little bit earlier, you're going to have better results with that second dare. So it is, yeah, I mean, our protocol and what we have published on is the planned double dare using high dose antibiotic beads. But again, there's also pretty good literature that simply shows that doing a second dare relatively early after the initial dare also improves your overall success rate.
Perfect. Do you do that on everyone with acute PJI, or do you save it or reserve it for high-risk patients?
No, that's become routine for us. It's hard for us not to do that when we've published on results that seem to consistently show a pretty good success rate. And so anybody that we have either post-operative or acute hematogenous that presents, they're going to get a double dare at our place.
And do you do it both for the knees and the hips?
We do it both for the knees and the hips, correct?
Okay, what was the recommendation at the ICM?
Well, the recommendation, it was I didn't really I wanted to we presented sort of more as all the ICM questions are intended, a more broad overview of the literature. And so the ICM question was not specific to a planned double dare. It was just on the benefit of a second debridement. And that received, boy, you got me now. I can't remember if it was strong consensus or just consensus, but I think it was viewed favorably by the delegates there that a second dare is beneficial.
Yes, exactly. That was the recommendation. So, and it's actually a change from the 2018 recommendation, because in 2018 the ICM said there is no role for a second dare. If you have one dare and it failed, you need to move to resection arthroplasty. But here it says, yes, you might want to consider a second dare, particularly if it's planned like you were talking about.
Yeah, I mean, the interesting concept is that I think historically we've had this notion in arthroplasty that, it's one and done. If you do one debridement and it fails, game over. But when we look at many of our surgical colleagues, when they treat infection, it's oftentimes that patients will return to the operating room a couple of times to treat an aggressive infection. And so I think that notion, again, you don't want to prolong the treatment for the patient and do multiple unnecessary procedures. But I think if, a periprosthetic joint infection is obviously a dramatic event for the patient and difficult to treat. And so, doing two debridements in close succession where you're not having to re-expose the joint and basically just open up the joint a second time and be able to debride the joint, I think makes some sense. And I think the results support that.
Yes, that's fantastic. And I am really, really grateful for you to have worked on this, Mark. Um, yeah, we had the question was, is there a role for repeat dare in patients with acute PJI of hip and knee? And the recommendation is in patients who have an acute PJI of the hip and knee, repeat dare to increase the overall success rate of infection eradication when performed after failure of initial dare or as a planned two-stage double dare is effective, 78.2%. So double dare appears to have found its way into our armamentarium of dealing with acute PJI that has unfortunately a very, very high failure rate. Thank you for your dedication and your work on this front as well as many others. I can't thank you enough for your sage guidance and leadership of the ICM. And of course, I'm grateful to you for your friendship. Thank you for taking time out of your very busy day. I know you have a clinic to go to. Thank you for making time for us to talk to you. Any
My
last minute words, Mark, before we finish? Thank you again for everything.
No, I just the ICM was a fantastic event. I mean, thank you again for having the energy to organize that. I think, it can really disseminate a lot of valuable information internationally, far beyond a US audience, and it was great to be involved, and I appreciate always your friendship and your support.
Thank you so much, Mark.
All
And
right,
then
Jake.
send me an appointment for my double hip replacement soon. Okay. I'll see you. Talk to you soon. Thank you. Bye, Mark.
Bye.